So a very warm welcome to the beautiful building that is the Royal College of Physicians. I have two housekeeping notes just before we start. I've been asked to tell you. One is that there is filming going on, which you might have spotted, and it is an on-the-record event. Okay, so, and the other thing is that there is wine afterwards, which is really good, especially as we're starting a little bit late, for which I apologise. So the title is Data and Analytics, the New Medicine. And when I think of data, like you, I probably think of big data. Is that what most of you are thinking? And even though I've been writing and reading about big data for quite a while, and particularly in terms of healthcare, I still don't really know the threshold at which data becomes big data. And I think the best definition that I heard was that data becomes big data at the point at which your organisation can no longer handle it. So I think that's a really good definition, and we might want to expand on that. So big data is everywhere. The NHS is coming up as an issue in healthcare. We know that it's a great repository of data, and we know that there are more than 240 million NHS visits every year, which is potentially generating its own data. So there is a lot for us to talk about, and we also have the American perspective too. So we've got a really superb panel. So how it's going to work is I'm going to ask each of them to introduce themselves in turn, just say who they are, what their affiliation is, what they interpret big data to be, and perhaps one of their great hopes for what data can achieve, big data in healthcare can achieve in analytics. After that, we're going to structure the conversation on sort of four main lines, and so that will keep it coherent and focused. And then after that, we'll have a Q&A. And after that, that's when we get to the wine. So I'm going to ask each of the panelists to introduce themselves, and we'll start with you, Margaret.
So I'm Margaret Johnson. I'm the Academic Vice President here at the College of Physicians, which is an elected position. In terms of my day job, I'm trained as a chest physician, but most of my work has been in HIV. So what do I think big data is? So I suppose it's the collection of large amounts of data, and as you say, more than your own institution can handle. And I see that there are clearly enormous benefits from that, and I think particularly we should be in a very good position in the UK with 62 million people looked after in that same healthcare system to use this for research and also to improve patient care and the quality of care in the UK.
Great. Well, I'm Ewan Ashley. I'm a professor of cardiology and genetics and biomedical data science at Stanford University. I don't sound like I come from Stanford University because I was born and trained in Glasgow. I did a PhD in, so I did my what I have to now call an MD. Of course, it's not actually an MD, but I did my medical training in Glasgow. I did a PhD in Oxford in my junior house jobs and then moved to Stanford about 14 years ago. And I joined the faculty about 10 years ago and now concentrate on a variety of different things. My lab investigates and the application of computational biology techniques to genomes and to the human genome, and in particular its application to medicine. But that has taken us into this new world of bigger data where we look at multiple different data streams and integrating them. And so I currently direct an initiative across Stanford campus to bring together those in the School of Medicine who mostly have questions and data with those in the School of Engineering who mostly have tools. So I usually say I was born a geek but trained as a cardiologist. My definition of big data, I think my first definition is usually one similar to yours, which is, any data bigger than you're used to dealing with is big data to you, so that's key. For a while we said it's anything you can't fit on an Excel spreadsheet, but then Microsoft made Excel spreadsheets, so suddenly take millions of rows, which they didn't before, so we had to change that. In reality, when I think of big data and I think of it's really what it can do. And I think back to this very classic paper that was written by some of the data scientists at Google that talked about the unreasonable effectiveness of data. And it was based on an earlier article by Eugene Weigel that talked about the unreasonable effectiveness of mathematics. And what it basically came down to is that once you get to data that's large enough size, you can start to pick up patterns. Their example was one about the leap forward in our ability to do voice recognition and to do natural language parsing of audio. And so I think it's when you can move to the next step in terms of unsupervised analysis, being able to pull patterns out of the data itself, that's when I think you're really in a big data world.
Lovely, thank you.
My name's Charlie Davey. I'm a neurologist from North London. I'm also from Glasgow, so we've almost got a clan going here.
Yes, right, definitely there.
And I'm also managing director of UCL Partners. So that's a partnership that brings together an academic health science centre linked to a population focus through an academic health science network. And we also have a number of functions. So we run clinical research trial facility, applied health evaluation function through a clerk, and an educational provider function. But data runs through all of those different functions, and what we try and focus on is how we can take discovery science both from industry partnerships and academia and link that into patient benefit, very much focused around the patient and end user. And so we have multiple examples where we use data, but often that's across large populations or across multiple organizations. And I'm particularly interested how we can move from the sort of capture to data to the insights that we can then meaningfully use to benefit patients, and then feed that back in a sort of continuous improvement cycle.
Great. I'm Lloyd Minor. I'm Dean of Medicine at Stanford, and my field, my academic background in medicine is in the field of otolaryngology and the science related to how the balance system works and disorders of the balance system. When I moved to Stanford 5 years ago to become Dean of Medicine, it was evident that we had these enormous resources both at the university and also in our community around us, resources related to data and data science. We saw that manifested in fields like genetics. We see it in clinical fields, in cardiology, and it really is a galvanizing principle and area of focus for those of us on the faculty, and increasingly for industries and people in the broader Silicon Valley community. If I had to define big data, I think it's everything that everyone has said, and in a sense it's data, any data related to the health and well-being of people. And so it certainly pertains to data about our bodies, but it also pertains to data about the environment in which we live. We know, for example, that childhood asthma in many communities previously plagued with a lot of air pollution, that the incidence of childhood asthma decreases when the air cleans up. So that's, that's data related to health. The cause of asthma in those children is clearly environmentally related. Therefore, the data about the environment is pertinent to understanding disease and ultimately to treating disease. And I think that's both a challenge and an opportunity for data science, and that is how to bring in the data pertaining to the health of individuals and populations, and then derive information from those data in ways that can lead to improvement of health of individuals in society, and also of the care that's delivered to individuals in society.
So I'm Jem Rashmas. I'm the National Director for Disease Registers and Cancer Analysis in Public Health England, where I'm responsible for running things like the National Cancer Registration Service, the National Rare Disease and Congenital Anomaly Registration Services for England. And I've got into this because I am interested in data, and I wanted to go after data. I started as a histopathologist and a molecular biologist, and I cloned and sequenced genes. And at that point, which was back in the last century, it was clear that you could clone and sequence a gene. You could get ACTG off it very easily, and a company like Illumina would come along and be able to do it much faster. And that is a classic big data problem. But alongside that, it seemed to me that there is a second problem, which is that if we're going to understand the genome, we need to understand the clinical phenotype alongside it. And that is the bigger and more difficult problem. Not because it's intellectually more difficult to summon up that statement, but actually clinical data is complex and difficult and very varied. And I suppose my take on is clinical data big data would be actually to say, no, it isn't. That actually clinical data, there's a lot of it, but it's a data complexity issue. that understanding an individual patient and the ability to do personalised medicine requires a really deep phenotype and an accurate phenotype on each individual. And that is the challenge. We can't use standard big data techniques of just massing more and more data together and expecting the rare patient to fall out of that. We will find a few, but if we really want to use data to drive clinical healthcare in the clinic, we need very high resolution, high definition clinical phenotypes on individual patients linked to their phenotype, linked to their genotype in very large numbers. And that's what National Disease Registration is about. So that what we now run for the Cancer Registration Service in England pulls data on 500,000 tumours a year, and we follow that entire patient pathway, and we're obsessed by data quality. And we don't get that data quality by algorithm and by computers. We get it with registration officers who still need to go into clinical records and join data, because actually healthcare is so complex that there's no quick dash to high quality data. So having been at the end of the row, to me, I'm sorry, it's not a data algorithm issue at the moment. At the moment, the challenge for us is to get those very, very large clinical phenotypic data sets alongside the genotype.
That's brilliant, and that leads us on to the main structure of our conversation now. And I want to start each of our 4 themes with a provocation, if I may. But before I do that, one thing we haven't done, and I guess it's because it goes without saying, is nobody's questioned the premise that more data is a good thing for healthcare. And I just wanted to know if there was anything to say about that, or is it just so self-evident that more data is good that it just almost doesn't bear
I
conversation?
think you've got to be careful with more data. But I think we spent a lot of time worrying about type 1 errors, and in reality we can control, we have techniques to deal with larger scale data that we didn't before, and there are patterns that you can get. We worry about garbage in and garbage out, but in reality I think what many of the tech companies have shown us is if you have classifications, if you can wrangle the data, which is absolutely key, I do not disagree with that at all, there are patterns that can emerge from the data. And so I don't disagree with the premise.
Great.
But
Okay.
I'd be interested if other people
No, I
do.
mean, I agree. I mean, more data is good, but high quality data is even better. Yeah.
So our first theme, as you know, you're all clinicians really, you're already engaged with the data, but there's another party you have to engage, and that's the public. Okay, so my provocation is this, with what happened with the Royal Free and DeepMind, so as we know, that there was, the Royal Free had given DeepMind some data, some NHS data, patient data, in order for them to develop their Streams app for healthcare. And Dame Fiona Caldicott, who is the kind of data guardian, if you like, for the NHS, said this. She thought it was legally, I think, improper. It's absolutely paramount that this sharing of data is done in a secure and transparent manner, which helps to build public trust. Otherwise, the full benefits will not be realised and even some harm done. So how do you go about engaging and getting the public trust that you need in order to collect the data that you need in order to push forward?
I think it's about transparency, isn't it? Because, I mean, I look after HIV patients, and I established a cohort 25 years ago collecting data and getting consent from patients to share for research purposes. And almost, I mean, the number of people who actually opted not to share that data was absolutely tiny. And I think if patients actually understand why you're doing this, that it's going to be looking at outcomes, comparing outcomes, that they are, more than happy to
So
do
your
that.
patient group is very on board.
And also a patient group who were, but if you think 25 years ago, the stigma around HIV, confidentiality was, of huge concerns to them.
Yes.
I think there's the trust issue as well, and it's interesting. I think generally the NHS and healthcare traditionally has had quite a high level of trust by the public that we can use their data safely and appropriately. And there was a Mori poll that came out in 2015 that asked that question. Do you trust? And it was across multiple institutions about the level of trust that they had to use data appropriately. In fact, the people who came out highest in that group were GPs and GP surgeries at about 41%. The NHS was about 36%. When you come down to academics, you're down to about 25%, and then it goes down to you get to the press, and it's about 4%.
So I'm the perfect person to be asking this question.
Well,
about trust.
I'm very interested to hear from my colleagues from here, because I still read the papers on both sides of the pond, and I really recognize a difference between the patients I'm seeing in California who aren't asking me about the privacy of their data on a daily basis. They're asking me what value it can bring. And what I'm reading, when I read the papers from here, are great concerns about privacy and these sorts of quotes that you made. And I'm just very interested in is that because it doesn't quite fit with the data that you just said from, I mean, if there is great trust in the NHS, where is it breaking down?
Well,
So
I think
when there are these concerns, there's very little rebuttal to those reports.
But I think also we dropped the moral context. As we were seen to try and commercialise data. Things like the care.data was seen to be taking data with an overt commercialisation. In the cancer registry, I actually have a legal gateway to collect data without the need for consent. But I'm still bound by exactly the same rules as all of us are in clinic, which is the duty to protect that individual's confidentiality. And I think what we did was we haven't explained that we need to maintain our trust. It isn't about the moral limits of markets. I mean, I've just been reading Michael Sandel's book. It's that I think we got wrong. We tried to. People felt we were there to commercialise their data.
Is this a barrier now?
Yes, I mean, I think it's a very difficult process to reverse that. We've damaged the trust that there is in the system. And as someone who works for government, I think you're not trusted as a journalist. Government as well is not trusted.
Lloyd, what's your perspective from
Well,
over
I
the pond?
think data security is for sure an issue, but the existing systems that we have, particularly in the States, are not doing a terribly good job. In fact, one could argue they're doing a very poor job, given that I think it's over 45% of Americans within the past couple of years have had some sort of breach of their health records from the large breaches of insurers. So because we have such a distributed system right now of dealing, storing, maintaining databases across multiple different health systems that are not really interrelated, interconnected, nor do they necessarily share common standards for data security, it's made the system very vulnerable to breaches. And we probably all can learn a lot from, independent of the valid concerns about commercialization, we can all, I think, learn a lot from technology companies that have made it their business to secure data and that have as their primary business model making sure that data is secure. And you can comment on that in terms of some of the partnerships that we've developed and the types of security measures that have been put in place.
Yeah, as we were transitioning, we were setting up a new genomic service for the hospitals at Stanford, and this is taking us from a range of, our current medical record system has a few hundred terabytes of data if you exclude the imaging, but we were moving into a world where we're going to be sequencing genomes on a large number of individuals in our healthcare system and looking at petabytes of data. And the question came up, how do we keep that most secure? Very large data, how do we keep it secure? And so we got a group together and looked at our new data center that we had at Stanford campus and everything, all the facilities and people that we had to keep that data secure, and compared it to what was available at Amazon Web Services, at Google Cloud, at Microsoft Azure. And we couldn't compete. I mean, we were talking a little bit yesterday, Google have a room of 200 people that spend their day hacking the servers, trying to bring it down. There is no university, no healthcare system, no NHS can compete with that. The tech companies, this is what they do for a living. They lose if they have a breach. So I think what we did over time then was negotiate a deal with Google Cloud, and so we now store our genomic record data with Google Cloud in a secure manner. My
perception in the UK is that the anxiety that the public and some patients have isn't particularly around data breaches. It's around the misuse of their data. Yes, of it being sold, commercialised. The Google DeepMind story.
What would you regard as a misuse of data?
Well, I mean, the Google DeepMind anxiety wasn't about it being hacked from Google servers. It was the fact that the social license of the patient to tell the physician about their medical history was one of trust, and that process of trust had been breached.
Was there any focus, just for my interest, on the potential benefit that?
Yes, actually, the technical reason I think was. I think wasn't it the technical reason was that because the use of the data wasn't involved in a care path for that patient, and it was for the other use, not not to directly benefit the patient that was the issue.
Well, as Margaret said, I mean, the other thing, it wasn't transparent as well. The patients didn't know.
Yes.
Yeah. So it came as a surprise.
So where do we go from here then? You need your data, or you want your data. Some of you are teaming up for storing it securely. You're teaming up with corporations, companies. How are you going to square the circle? Because now you've kind of got in bed with the devil, in a way.
Thanks. I think the challenge actually is to go back a step and to return to the clinical world and to establish that dialogue back with the patients and the public, so that the data set becomes wrapped in patients and the public. That you collect this data and you say, we got it wrong. I think that's the first thing you have to say. You actually have to be honest and say, we didn't get this right. And then you need an appropriate group of patients and the public who are capable of recognising the value but also the risk. And that then is an open dialogue.
So is PHE, Public Health
Yeah, very
England,
much so.
engaged in doing that?
Well, I mean, it's interesting. The cancer registries, we have an absolute right of opt-out for patients. And all that the patient needs to do is contact me or the system and ask to opt out. Now, you'll know there's a national opt-out here, and when that went live, 1.2 million patients opted out. In the Cancer Registration Service, for the last 10 years, we've had 7 people opt out. Now,
it's amazing.
We were, yes, but we were then said, well, that's because nobody knows about you. And actually, the cancer charities were then commissioned, the big cancer charities, to do a survey, and they brought Maury in, and guess what? Nobody knew about us. Embarrassingly so. So we were then challenged with, well, the reason nobody opts out is nobody knows about you. So we've been doing a publicity campaign over the last year where everyone knows about us. I go on the radio, sitting in audiences like this. There's no security by obscurity. And our opt-out has shot up. It's shot up by probably 100%. Yes, there are now 15 people who've opted out. Yes, but the thing that is really encouraging about that is, I can tell you, they don't opt out with a simple form. I get a 7-page letter, yes, of extreme anger. I've had 3 reports to the Information Commissioner. I get subject access requests. Each one is taking 2 days of work to deal with. And that's exactly how it should be. But I think what I'm getting is an assay of the awareness. And that actually what we're seeing is that patients are now supporting us, and I think that's the model. We need to step back and take more patients with us. That absolute right of opt-out I have absolutely no problem with. I'm prepared to stand there and say, anyone who wishes to opt out from my registration system can. But if you wish to, then please understand the consequences of that. It's not blackmail, but I cannot deliver future healthcare for you in all sorts of ways.
It seems that's the key, isn't it? I think Margaret's point is absolutely well taken. If we explain the value to people, then in general, if you say, donate your data, it can help your neighbour, it can help your friend, it can help your relative, it can help you.
And your children, and the generation.
Very few people, if you explain it to them like that, as you did with the HIV study, very few people will opt out.
And when patients realise that data actually isn't shared, between a hospital and a GP, and between a GP and social services, they find that completely inexplicable.
I think there's also a sense that certainly the collection of health data here is changing because everybody wears fitness trackers.
Right.
So even if your Apple probably knows more about you than your GP, in a way.
And I think a point that you raised, and that is when people understand the benefits to them and their families from having a registry, from having the data. Technology has disrupted every segment of the economy except for healthcare, right? And in both of our countries. I mean, when you think about it, how do we order books? How do we increasingly order, goods for our homes? It's through our interface with technology. How do we do financial transactions? We were talking last night about how there are no branch banks anymore, right? We do it through automatic teller machines or through online interactions. But the changes that have come about so far in healthcare delivery or in the access of each of us as a healthcare consumer to our medical records have been relatively modest. And once people, I think, once we are able to deliver data and information in a way that's meaningful to people, and once people embrace that as a part of their lives, just as we embrace financial transactions in a technology-driven way, then we may see a change in the I hope we would see the change in the attitudes towards the power of big data.
I think the other thing that's, I'm in a privileged position because actually I've got cancer patients. And it's the cancer patients themselves that they already know. And we run a national cancer patient conference, where we show them the value of data. And there are, the patients with us run sessions. So understanding how the data is affecting them is important. When you get a general public, there's an anxiety. Yeah. Once you become the patient and you see the benefit.
And there's an obvious reason why a cancer patient would want to assist in that way. I'm going to move us on to the next theme, which is the doctor-patient relationship. And what it means for doctors, actually, and physicians, clinicians, sort of with patients. So my provocation is this. There's a report called the Smarter Health Report that came out recently. And almost the top line is this. It would be impractical and prohibitively expensive to fulfill all the NHS's analytical need through more hiring. In other words, clinicians had to get up to speed. They have to almost become data scientists or certainly acquire the expertise. So what does it mean, this new era of data? What does it mean for physicians and clinicians, people that are actually meeting patients on a regular basis? Margaret, do you want to tackle that one?
So, I mean, certainly it's something we're thinking about a lot in terms of the future physician. So physicians being our clinicians. And, you know, realising that actually the clinician of the future needs to have different skills. And, you know, that in terms of analytics, you know, the research analytics, I mean, our, you know, clinicians, you know, have not necessarily had, you know, training in this, either in medical school or then in their postgraduate training. And, you know, certainly we, you know, are, you know, very much trying to think about making sure, as we've said, that obviously collecting the clinical data, the phenotype of the patient is really important, and making sure that they're collecting how to collect the correct data, but then also to have much more skills in terms of research analytics.
So are the students who are at medical school today, do they get taught anything about data analytics?
I think a small amount is the answer.
Let's take this on. What's the view here?
It's a very crowded curriculum.
We've certainly been introducing it in the curriculum at Stanford. And I certainly think that it's going to be important for the next generation to understand what is possible with big data. But this one I might argue with your premise. I'm not sure that physicians need to be data scientists. Mm-hmm. I mean, I love data. I was born a geek, as I mentioned. So I mean, I was always going to love playing with data. But I think most physicians aren't drawn to medicine because they love data. I think it's really the responsibility of the data scientists to make sure that the doctors don't need to become data scientists. And I think that in the same way that we don't necessarily need to understand all the pharmacokinetics and pharmacodynamics of every drug we prescribe, we do need to understand what those principles are, and we do need to be able to look them up at the time. I think that's how we need the next generation to be able to understand data science, know what's possible, know where they can go to implement those tools or who to talk to, but not necessarily do it themselves.
Yeah, and I think it's an education in the round, so there's much more interest in training undergraduates around quality improvement methodology, of which data analytics is an integral and important part. But actually that's much more focused on an outcome, which I think is important. There is absolutely a need for greater informatics and analytics capability within the health service, and you know, we do have examples of some champions. I think we've got the only trainee CCIO in the country at UCLP, which is a great Chief Clinical Informatics Officer, which is great to develop leadership at a young age. And there is now within NHS England and NHS Digital, they've just awarded us a tender for a digital academy to train people in the future. But I think it'll be a specific cohort, not everyone. Yeah.
Right. I think the field of clinical genomics provides a good example. I don't think that every physician needs to understand how association analyses are done on an algorithm basis, but they for sure need to understand the benefits and the risks associated with the interpretation of an association analysis. And they need to be able to make informed recommendations to patients about when it's appropriate to have genomic screening and how to interpret that data. So it involves an understanding overall of what the approaches and methodologies are, but not, as Ewan was saying, of being the data scientist driving those approaches and methodologies. Similarly, for the very important area you mentioned of quality improvement, you know, of being able to be a contributor to the data that will, and the analytics that will drive quality improvement is important. developing the algorithms for physicians is not really important.
There's a slightly changed encounter though, isn't there? I'm sorry, I've jumped in there.
No, because I think I'm going to pick up where you may be going, which is that actually, when I trained in medicine, what we emphasised was how to make a diagnosis. How to find the diagnosis, take the history, examine the patient, do the tests, and we've progressed on that. My feeling is that actually, if we really go the full length of personalised medicine and we have real data, then the system will make the algorithm. That actually the diagnosis is done because actually I need to know about the 15 other cancer patients who are like you and how they've been treated. And there's no way that I'm going to know that or be able to look it up from the system. So the AI system that's sitting on the back wall of my clinic is going to tell me how to treat that patient. And suddenly, me as a doctor and a diagnostician, I'm immaterial. And we're seeing that already in genomic medicine.
Well, that's what I'm wondering, because at the moment, if I go to see my doctor, I sit with my doctor, we talk, he puts information into my records, but generally kind of says, well, there's this and this. But then, an encounter of the future is you go to see your doctor, the doctor says, well, the algorithm says you've got this, or you should be treated with this.
You don't see the doctor, you see the algorithm.
Yeah. Yes, I see it.
Yes, an avatar.
An avatar,
exactly.
an algorithmic avatar with the stethoscope. But can you see that there's a different interaction there? How do you kind of how do you
it's
deal
got to be
with
augmentation, I think, hasn't it? I mean, we have to. These are very powerful algorithms, but I think the idea, and some people believe it's going to be the avatar, and we don't need the doctor, and we should forget all that. But it's got to be augmentation. It's got to make the physician better to be able to spend less time dealing with the data.
But when you say better, are they a better diagnostician? Or are they better at eliciting the crucial things in the history? The problem is the patient never comes in and says what you want them to say.
Yeah.
So the art is to recognise what's important in the history and the examination that I put into the system. But no longer do I have to sift that evidence to come up with a differential diagnosis. Yeah. The system will do it, along with a genomic background and everything else. That's your risk profile now.
Charlie?
As a neurologist, I actually feel that quite a lot of our role goes beyond diagnosis and clinical interpretation and a very medical model. A lot of patients I see with neurology, with long-term conditions, their problems are not to do with their direct clinical disease. It's to do with where they live and not having access to various services that are beyond my control. So there has, I think, to be a transition about what we offer patients if we want to be part of the care that we provide for them.
That sounds quite major.
It is major.
But John, as a neurologist,
you still have that relationship to coordinate to make sure the other things happen.
When I did my neurology training, in the last century, what we actually had to do was examine the patient to work out where the neurological lesion was. You don't do that now. You put them in the scanner.
But some people do.
But I think the key is
That's still old school.
The key is using the computers for the things that they do best. I mean, it could be the diabetic retinopathy. The computer can have the knowledge of 1 million scans. Every time a new scan is done, the computer can absorb it. It's going to need classification. It's going to be trained at some point. But eventually it's going to be much bigger and faster and better than any human.
So it's about learning to use the technology with discrimination.
Right,
really.
Absolutely.
I'm going to move us on to the next theme. And if you think these are very rushed, I can see why, but you will get the chance for Q&A afterwards. So the third theme is infrastructure. This is an interesting one because I thought, well, I know the NHS has my data, but I don't really know how it works with my local hospital, which happens to be the Royal Free, my GP, if other government agencies are involved. I actually don't know much about the infrastructure of how medical data is held, and I'm just wondering, do we have an infrastructure in place in this country and in the States that can handle the coming kind of online of big data in healthcare, or do we need to build it?
So my own feeling is that it currently is remarkably fragmented. I mean, the data sets sit with multiple gatekeepers who are, for more political and cultural reasons rather than technical ones, don't wish to share it.
So who are the gatekeepers, if there are many of them?
It can be multiple sources, through commissioners, through providers, through multiple sources where the data lies. Actually being able to access them. So Jim talked about having access to multiple data sets through registries. That's the exception in medicine, I would suggest.
Yes, and I mean, essentially what we've had to do is go under the wire. I think one of the things we've done spectacularly unwell, I think is probably the best way of putting it, given I'm a civil servant, is these national initiatives to try and stitch our data together. The system is too complex and too difficult to do that. I know there's a view from North America, that the NHS has got a single badge and that the data is harmonised. Actually, when you get over here, it's as balkanised as everywhere else. And inside an acute provider, there are different systems. And so, when you ask Charlie, it is so fragmented. And so what we've done actually in the registries is, how do we get this data? Well, actually, we've killed some of the holy cows. And one of those is data standards. We simply go into an organisation and say, do you know anything about your patients? And you know their name, address, postcode, date of birth, and then what we do is we develop systems that will take data out of any system so easily that we just take the data, we take the pain at the centre and stitch it together. And I think that model is something that then scales. Because what we found is scaled, in 2011 we did 500,000 clinical records. Last year we did 32 million, and next year we'll do 250 million records. And all of those are coming out every week from every system, and yet the NHS is still going through this churn. So I think we need to change our mindsets. And I think there are lessons out there. You've got it in CancerLink in the US. There are examples where these very fragmented healthcare systems can begin to join their data together.
So, Lloyd, give us the picture from California, which I imagine is way out in front of
I think
anything we're doing.
The fragmentation of the data, of healthcare-related data in the U.S. is certainly palpable every day for those of us who are treating patients. I mean, it's easier for me to, obviously easier to go to an ATM and perform a financial transaction than to get my medical records, from a primary care physician to a doctor in the same building even, practically the only use of fax machines anymore is in transmitting medical. I mean, how many businesses do you know that use fax machines outside of physicians and hospitals today, right? So we're very, very far behind. But the resources exist. I mean, it's not like storage systems don't exist for data sets the size of clinical data systems today. They do exist, but they're not being utilized by, by provider organizations or healthcare delivery systems. So how can we, get the technology deployed in a way that makes the data useful for deriving information? It's going to drive better healthcare and a learning healthcare delivery system, but at the same time, protect the security of the data and, very, very importantly, as has been mentioned several times, earn the trust of those patients who depend upon us for their care and also to maintain their privacy.
Yeah, I think that we've vastly underestimated the investment required to take today's system and make it work like Google or Apple. We forget that these companies are only a few years old. So everything that Google has done has been built, in the last 10 to 15 years, much of it. Whereas our healthcare record systems, a bit like our airline system, was built in the 1960s. And so the investment it takes to take a system that's 50 or 60 years old and make it perform like one that was only invented in the last 10 years is at least one, if not two orders of magnitude greater. And I think that we haven't really grasped that yet. I see that on both sides of the pond.
I didn't quite squeeze my provocation in there, and I address this to you, Margaret, because Med Confidential, which is a patient sort of a privacy group or privacy group, said this: what the NHS has been doing with data at a national level is basically chaos. Would you agree with that?
I think progress has been very slow, but I think it's actually reassuring to hear that in many ways you're having the same problems. And I think that, as we've said, I think, getting the trust of the public to move this forward. I mean, I actually was speaking to a patient about this evening and coming to this meeting, and I said, what do you think about big data? And their response was Big Brother. So, so
we're back to the engagement and trust.
I really think, that why it has, the slowness is because of the lack of trust.
But here, in order to make the best use of the data that we're getting, Jem, I'm looking at you actually for this, but and somebody mentioned you talked about and I think the investment required. Yeah. I mean, here it has to be the government that invest in it? And is there any hope that
Well,
that's
I think there is.
or
It's been significant. I mean, you know, we
private.
helicoptered in Bob Wachter, you know, and David Brailer, you know, to give us advice. And I think, you know, if you read their report, which is called Making IT Work, it really is saying give the system time. I think the other thing to recognise, this is very hard. This isn't a simple problem. It isn't a single organisation. The complexity of healthcare data. You know, UCLH just about to put Epic in. You know, we did that in Addenbrooke's. It's a painful process, but that doesn't give you interoperability. That solves your local environment.
Oh, I see.
Yeah, so, you know, when you do deal with this at a national level, those are really very, very difficult problems.
And there's no sense that actually we go back to the drawing board, scrap everything and start again.
I think
just too difficult.
I think you want to go on a controlled incremental process, and I think that's where the strength of the CCIO comes in,
Right.
is that you get people who really understand on the ground what you need to deliver clinical benefit, as opposed to let's turn ourselves into the banking industry. Now, when we did that for Connecting for Health, we managed to spend £12 billion, and about all we got out of it was the expenditure of £12 billion.
I don't think you can start again, but you can agree to have a system where people collaborate, use similar standards, governance and assurance, which then allows you to overcome some of those problems.
Okay. Thank you. We're going to move on to our last theme, which is precision health, targeted personal medicine. So here's my provocation taken from Nature, which was a perspective published in 2016. I think it was called the precision illusion, precision oncology illusion. And it says, precision oncology has not been shown to work, and perhaps it never will. It remains a hypothesis in need of verification. So we're in this brave new world of having all this data. We're telling people that telling patients that the more data we have, we can collect. We can really sort of hone in and give you bespoke treatment, really, in a way. Can you? Is that really what you're working towards? Or
It's transformational. I mean, again, to come back, when I trained, I went to Mount Vernon, and I walked into a ward of teenagers and young adults with melanoma. They were dead within 6 months. You look at a BRAF mutation now, and you see the scans, and you see people with a disseminated melanoma, and it melts away. It doesn't treat everyone, but when you see that effect, or you see the effect of Gleevec, and CM, I mean, there are extraordinary targeted medicines. Things that we only dreamed of being able to do. I mean, as a pathologist, I've done PMs on people with disseminated melanoma. These are scary conditions. And yet when you see a single medication like that, targeted to the right individual, have such a profound effect, that's what gives you real knowledge of, and that's precision medicine. And the problem is, you can't do that without the big data and the quality data to find that right patient. That's where the problem is that we can't segment our patients down to small enough buckets to know this is the patient who really benefits from that.
Mm-hmm.
Yeah.
I think the problem is, so at a disease-specific level, I think you can aim towards that. I think the difficult is when you start to look at population health level. And then, if you take work from people like Michael Marmot, who have shown very eloquently in large cohort studies, the determinants of health are largely based on things out of acute health problems. It's about behaviour, about social, about access to education. We don't have access to that information that makes anything precision.
So how do you square that? Because we are moving to this age where we're expecting slightly more personalised medicine, and yet, you're, I suppose, holistically, you are still looking for population interventions that make a difference.
We're on a journey. I mean, in the same way as 20 years ago, we understood single gene mutations and the effects. We now understand more complexity there. Ultimately, we'll get to stratified prevention, personalised prevention. You'll get a list earlier on in your life, after your birth.
Are you ahead of that? Are you
on
this curve, Lloyd?
I mean, that will that's where we will end up, but it's not going to happen quickly.
Is it happening any faster in the States?
I think it's within grasp. The enablers that have driven the changes that Jim was just mentioning in precision medicine, that is genomics, big data science, and applying those to the treatment of severe acute diseases like cancer, those enablers also are very pertinent to prediction and prevention. In parallel, we're seeing a mini revolution at present, but hopefully will expand rapidly in advanced diagnostics. It's important to remember that as recently as 5 years ago, the only validated test we had to detect a chromosomal abnormality in a fetus was amniocentesis, a procedure that has about a 2% risk of fetal demise, an invasive procedure. Today, the use of amniocentesis has been dramatically reduced because from a simple blood test in the mother, you can get the same information and diagnostic accuracy about chromosomal abnormalities in a fetus. You know, that's revolutionized prenatal diagnosis. It's a beginning, right? But an important beginning that I think has a promise to spread. So through the deployment of data science, of genomics, through advanced diagnostics, we'll be able to get to, I think, in the next decade, the type of regimen that Jim was describing, and that is that for each of us, we will understand our propensity for disease, and we will be able to tailor interventions, lifestyle, medication-based interventions, that will dramatically reduce the probability of those diseases occurring and enable us to diagnose them much earlier when they do occur, so that we're not dealing with this type of severe advanced cases that all too often have poor outcomes.
Actually, that's
Will
one of
your
the things.
healthcare system support that?
Well, you know, I think the answer to that question will come in part from
the rich, well-insured.
Well, also, how many of the advances will be like neonatal chromosomal detection in a maternal blood sample? Will the healthcare system support that? You bet, because it's vastly less expensive, as accurate, and without any risk. So almost overnight, that has, you know, transformed prenatal diagnosis, right? Hasn't necessarily been communicated in that way, but it has. Now, if we see more advances like that, yes, they'll be very rapidly adopted.
So you don't think that the hope is outpacing the reality?
I think we have to be careful about how we transmit the message so that we don't raise expectations beyond what we can deliver. But we have enough tangible evidence that it's within our grasp that for sure that should be the direction in which we head.
But there's also, is there also an issue of, you raised a good point which we haven't covered, which is one of the great hopes for generating this data is that intervention is earlier, perhaps even before things become symptomatic, which is quite an interesting idea. But also, don't you, if you are going to intervene, how does it change the nature of that intervention? Because you're almost kind of, you know, you're being a soothsayer in a way.
Well, we do it through screening programs already. So I mean, the whole aim of a screening program is to detect. If you could look for circulating DNA from a tumour and detect it, you know, 2 years before it becomes a mass, then, you know, the therapeutic outcomes of that are phenomenal.
Yeah, it's amazing that in a way we think ourselves of ourselves as healthcare providers, but in reality we wait till people become ill and then they come to the hospital and then we try to work backwards from that to try and work out what happened. And you know, one of the examples, digital health is a new thing. You mentioned Apple earlier, and certainly many of us are wearing watches that can detect at least heart rates right now, and most of the companies are interested in detecting heart rhythms. You know, why do we wait till patients have a stroke and then we put on a monitor and see if they have atrial fibrillation? You know, it would be possible to test for that earlier, and then perhaps we could put them on an anticoagulant beforehand and prevent the stroke before it happens. I think there are enough examples. We need to test to see if it makes sense to do that. But if the cost of the monitoring becomes either negligible to the healthcare system if people are already wearing these devices, or you know, or minimal in relation to the stroke being the largest the repository of investment in the healthcare system for long-term care, then you know it's likely that these could be cost-effective interventions.
There is a skew there, of course, towards the better educated, more incentivised population. But you can think of other mechanisms, so work that you can do in schools around education, which can then have a ripple effect back to the parents who are at risk of things. So there are mechanisms that can...
I mean, I think, you know, as a pathologist, one of the things I used to do was spend my time in the pathology museum. You know, and it's a wonderful place. You find pots of specimens taken from 200-300 years ago, where you're looking at pathologies that you don't see anymore. Unfortunately, you don't see them anymore because they're being treated.
Yeah.
It's not that they don't exist anymore. And so I think, history tells us that it may take 200 to 300 years before you see that rheumatoid heart disease quite as well as you can see it there. But actually, we are going in the right direction.
Excellent. I think that's a really... Did you want to say anything finally, Lloyd? I think this is a great point at which to wrap up the conversation here, but continue it with a Q&A. So I'd very much like to invite you to ask questions. Please say who you are and where you're from. That would be really helpful. There must be some questions. Yes, please.
My name's Aaron Shona, consultant at Whittington Hospital. So I was just thinking about your question about doctors needing new skills. And I think what I've noticed over my career is that in, I don't know, 15 years ago, when I was writing discharge summaries for my patients, I quickly write a discharge summary in 10 minutes and send off to the GP. And now my juniors are taking half an hour, 45 minutes, inputting all the data from the admission. And that's, so I think what we need from the tech companies or from, is a way of getting hold of that information and doing it in a far more efficient way, because the moment we're using all this medical manpower just to input data rather than, they're not being data scientists, they're being data inputters.
Right.
I think acute care has been particularly bad at this. I mean, when you talk to some GP colleagues, actually they've been a bit more advanced in using sort of digital solutions which have become a bit more automated, a bit more easy, which is fundamental, because if it becomes difficult to use, people find ways around it and don't do it properly. So I don't know why acute care has been so bad, but it really has.
I think in America, the electronic medical record is one of the major contributors to physician burnout. Many surveys now show that 50% of physicians in America are, by a variety of different criteria, burned out. And in particular, the average primary care physician in America is spending 2 hours in addition to his or her direct FaceTime interaction time with patients, working with the electronic medical record. And it may even be a mistake to call that FaceTime with patients, because oftentimes people are at the computer typing while they're in the room with the patient. So there's a crying need to dramatically change that, and this is something that I've been very interested in since I had to learn how to use an electronic medical record and take care of patients through an EMR. And just over the past year, I've seen a lot more interest from venture capitalists, from people who are extraordinarily tech savvy in tackling this issue. The issue being the interface between the physician, the healthcare provider, and the electronic medical record. In the United States, the dominant EMR systems really were developed as billing systems, and they serve that function very, very well. But they were not developed as aids to the delivery of care or to diagnostics. I, earlier in my career, discovered a clinical syndrome which has some hallmark symptoms and findings, which if you type in 2 words, dizziness and noise, into Google, you will get to web pages that will point you to this syndrome, superior canal dehiscence syndrome. You type in those same 2 words on the chief complaint line of an EMR in the United States, most EMRs in the United States, and you get no aid in making that diagnosis, which is why still most patients in the States with this syndrome diagnose themselves through a Google search. So, there's some fundamental disconnect here between the role that EMRs have played historically and the role that they should be playing. And I think now we're seeing some significant investments from venture capitalists and some significant engagement of tech-savvy folks in being able to solve this dilemma. And I'm optimistic that it will be solved, not nearly as rapidly as any of us would like, but it will be solved.
Yeah, I was reading today about an AI system that automatically pulls highlights from the US Open tennis tournament. And it basically takes a simple, it listens to the crowd noise, it looks at the screen, and if people pump their chest, and it takes all these things into account, and then automatically goes through 150 games and pulls out highlights. And it reminded me of one of, to which Lloyd was referring to, one of the students in our computer science department who contacted me asking if he could come to my clinic because he's trying to build essentially an automatic kind of listening device that would generate a medical record by sitting in the background, essentially doing the same thing as this does for the US Open, getting the highlights of my interaction with the patient. Now, that's going to take a while. I think we'll have to see how it works, but the principle that something could sit there, we have, I think the Alexa from Amazon is pretty common maybe in this country now too. I mean, the idea that voice recognition is good is out there, and that there can be something sitting in the corner that can understand is pretty well accepted, and the algorithms are very mature now for doing that. So it's not so hard that you could think of, instead of doing that, just as Lloyd was describing, you could just interact with the patient, and maybe a listening device could help put a note together for you.
Brilliant. More questions, please.
Hi, I'm Kat from Brunswick. Thank you very much for a great discussion. You've all touched on the sort of big tech companies and their ability to handle data. And I just wanted to sort of ask what you think, their role will be in the future, sort of within this, and the collaborations and partnerships, which still seem to be quite nascent.
Ewan? Yeah, I think that they will take different approaches. I mean, I think Amazon's health effort has only just been kind of leaked or announced. It's still pretty stealth. Apple, as many of you know, have been interested in the health sector for quite a while. And at least in terms of what's in the public domain, it's pretty clear that they're interested in dealing with healthcare data. Their approach, I think, is very interesting, which is to put the power in the hands of the patient, the person, so that they are making a way for your phone to be able to hold your medical record data. Now, I think that may well work in the States, where people are shopping around and saying, I'm going to come and see you because you're going to be the one who will download my data into my phone, and I'm going to take my data and go to whichever doctor I want to. So I'm quite optimistic that at least for a core amount of data, will actually be an interesting way forward. And I mean, Apple has 800 million iPhones in the world.
It's quite clever, isn't it, also, because then they own the data.
The participant, Apple doesn't.
What
Apple
is
have
the
been very, very careful to say that the data, and we work, and we work with them closely over something called ResearchKit and then HealthKit, which is the way of iOS of dealing with healthcare data. And they're very, very sensitive about the fact that data isn't going to Apple servers. In fact, in a recent US kind of fairly informal poll, but there was asked, who do you trust most of your data, Apple, Amazon, Google, and Apple actually came top.
Oh, okay.
Yeah.
That's something I didn't know. But it's interesting. I was interested in the data point because Sir John Bell published his kind of roadmap for the life sciences industry this year. And he made an interesting point, which is, he was talking about, basically, I suppose, the underuse of NHS data. But he said what he was warning about. He said what he didn't want to see happen was tech companies coming in, taking the data, using it to kind of create and refine an algorithm, and then disappearing back to San Fran where they could commercialize it. Because he said actually all the power is in the data, not in the algorithm. Actually, the machine learning aspect has been oversold. Is that something you would agree with? Particularly you, and if you've been...
Well, I think that I would never disagree with John, of course, but I think he's saying that now we have the algorithms, and so we don't need to make a fuss about them anymore. I think that's definitely true. I mean, I think that's where the magic lies, in the algorithm, and in my lab we build these AI algorithms, so it's not entirely straightforward, but we are definitely a mature place in terms of what deep learning networks look like and what they can do.
I think what he was saying is the data it's the data that matters, and actually it should belong to in this country.
And I think also the commercial value lies in the data sets, where you can get lots of people to provide an algorithm.
Well, so there's an interesting example, again, from our computer science department, where Andrew Ng, who was one of the real early machine learning and healthcare people, he was one of the people who first put YouTube into an algorithm and found out that the major principal components were a cat and a human face. So when you asked the computer to go and define YouTube, cat was first, human face was second. Anyway, he went to work for Baidu, the Chinese company, and now has his own AI company. But he also has a group still at Stanford, and they recently downloaded 30,000 patch monitors, so like Holter monitors for 2 weeks, that had been overread by cardiologists, and built an algorithm to essentially try to beat out a cardiologist. It's very sensitive for me, being a cardiologist. And they believe that they managed to do it pretty quickly. And so, but the key point of relevance is that the algorithm is actually open source, but the weights for the algorithm are not. Because if you have the weights for the algorithm, you can back calculate the data, and the power is in the data.
Yeah, the power is, and value is
yes,
in the data.
Yes, and so either algorithm have kept the weights, but the algorithm is in the public domain.
Very interesting. Charlie, you wanted to come in there.
Well, it was just the additional point to the question, which is, of course, the smaller SMEs are equally valuable as a source of innovation and creativity, and have an agility about them, which I think, you know, may lead to some significant disruptive innovation as well.
And I get the impression that when we talked about the infrastructure, really, and how it's going to develop, we really have no option but to go outside and seek outside partners, certainly in this country and in the States, for if we're going to get anywhere with this. Would that be true? Any questions? Yes, there's a lady at the back. There is a microphone. I hope it works for you.
Hi, I'm Sidi. I'm from a small startup tech company called Proof.work, but that's not what I'm here to talk about. The question I wanted to ask the panel, especially Stanford and California, basically the more patient data that becomes available and the more detail that you can build up about patients' information and their own personal data, the implications of what their potential for developing certain diseases becomes highlighted at an earlier stage, potentially in healthcare where you have to pay for your medical insurance, that can have some serious implications.
It certainly can, and that's why, you know, the ethical implications of who controls the data, who owns the data, who has the right to access the data, those are extraordinarily important ethical implications. You know, it comes up now with genomic testing that's available now in terms of genes that have been shown to confer, genetic alterations that have been shown to confer an increased risk of Alzheimer's disease. You know, clearly, you know, a life insurance company is, from the standpoint of a pure business model, would want to stratify patients based upon their whether or not they have or they don't have those genes. And so that's something that it is embedded somewhat in the laws governing the use of genomic information in the U.S., but those laws and those regulations are going to have to evolve as more and more powerful associations are discerned, which we know they will be.
And then that leads me on to, sorry, I've asked two questions.
Very quick, because I think everyone's anxious to
about
wrap
the
up.
patient owning their own data and how they choose to share that. And that would be the ethical aspect of who owns the data. That was just what I wanted to say.
Yes, it's a good question. Because I have heard of there was a university, I think, that was working on a model where patients own their data and then could kind of auction it out.
Yeah.
Which I think is a very interesting concept.
Right, right.
At the end of the day, I think insurance companies are always interested to use any data from anywhere to make better predictions. But that goes in both directions. I mean, if you're willing to say I can run a mile in 7 minutes, then they'll use that information, give you cheaper insurance. If you're willing to, for some insurance companies, put a thing in your car that shows that you drive at 30 miles an hour through every zone, then you get cheaper insurance. And equally, if you have to answer, they won't offer you insurance if you don't answer the question about smoking.
Or if you don't do the test.
I think the really interesting thing about that is the whole notion of insurance goes out the window with personalisation, doesn't it? Because you need the pooling of risk.
Yeah.
And so that will probably have its own implications.
But I think our tools for prediction just get better in the new era. It's not really fundamentally different from where we are now.
I think that's... Oh, I'm going to take one more question from the chap here. You put your... And very brief if you could, thank you.
Hello, I'm Giles Moe from Simmons. We've talked on the discussion about big data in the context of the body and the environment. Shouldn't we be thinking about big data also in the context of the cost effectiveness of treatment? Because Public Health England have launched a very interesting online tool which demonstrates that £1 spent on preventing bullying saves society a cost of X. And actually we should view big data as a force for reducing that sort of treatment. So my question is, have we missed something in our discussion?
So improving our cost-benefit analyses.
Yeah, I think it's a very important aspect, and so we run an innovation accelerator platform that tries to identify innovations that have a clear evidence base that we want to adopt and spread nationally. And one of the really important metrics about what we decide to take onto our platform, because it's run in collaboration with NHS England, is a very strong health economic argument about benefit. And we're doing that for a small number of companies, but I think it's definitely the way forward. I think we have a moral responsibility to show the cost effectiveness, so I think it's an important aspect.
And particularly so in the States, I would think.
Yeah, I think it ties into the precision health idea of getting in front of people before they're patients and thinking about prevention.
Exactly. And to me, that's the direction that will bring all of this together, and that is that including very much the value-based arguments in cost containment. If we prevent disease or we diagnose it and treat it earlier, that's going to improve quality of life, it'll improve longevity, and ultimately it will transform us from healthcare delivery systems really devoted to the treatment of severe acute diseases to systems that are more balanced across the entire spectrum of prediction, prevention, and treatment, but all aimed at precision.
I would like to end on that note, Lloyd. And I think what would really enhance our quality of life is if we all went out and had a glass of wine and some canapes, which I think has been very kindly provided. So before we do that, I would very much like to thank our panellists, Margaret Johnson, Ewan Ashley, Charlie Davey, Lloyd Minor, and Jem Rashbass. Please thank them.
Thank you.